Talking about cytomegalovirus, we covered toxoplasma and meningitis and so on. So in the herpes virus family, that can cause dissemination or localized end organ disease in people with HIV with advanced immunosuppression. So patients with CD4 counts less than 200 and advanced immunosuppression, you can see opportunistic infections like cytomegalovirus, which can infest the patients. So CME can cause invasive disease, including CME retinitis, which is widely seen, colitis, esophagitis, and neurologic disease. In persons with HIV, retinitis is the most common manifestation of CME-related end organ disease. So most clinical disease occurs in individuals previously infected with CMV seropositive, who have CD4 counts less than 200 cells per millimeter cube, and therefore represents either reactivation of the latent infection or reinfection of a new strain. CME retinitis in VLHIV may remain asymptomatic or can cause either partial or total blindness in one-third of the patients. So, coming to the clinical manifestations, most common clinical manifestation of CMV and organ disease is retinitis. It's peripheral retinitis, may be asymptomatic or present with floaters, scotoma, or peripheral visual field defects. Central retinal lesions are associated with increased visual acuity, decreased visual acuity or central field defects. Characteristic ophthalmologic appearance is of fluffy shadows, yellow-white retinal lesions with or without intraretinal hemorrhage with little inflammation of the vitreous. In the absence of ART or specific anti-CME therapy, retinitis invariably progresses rapidly within 10 to 21 days after presentation. Ophthalmologic examination may reveal the characteristic brush fire pattern with white leading edge advancing before an atrophic gliotic scar. So colitis occurs in 5 to 10% of the patients with CME infestation. More frequent clinical manifestations are weight loss, anorexia, abdominal pain, debilitating diarrhea, and malaise. CME can cause perforations as well, and patients present with acute abdomen. Esophagitis, small percentage of patients with HIV who experience CME and organ disease. It also causes odynophagia, nausea, and occasionally mid-epigastric or retrosternal discomfort. CME neurological diseases includes dementia, ventriculoencephalitis, and polyradiculomyelopathies. CME polyradiculomyelopathy, like GB syndrome, characterized by urinary distension, retention, and progressive bilateral weakness of the lower limbs. So when you suspect a patient with CME infestations, what are the leading questions that you need to be asking? Now, for CD4 count less than 100 and ART failure patients, ask for if there is any diminution of vision or floaters. Assess for visual acuity. Refer immediately to ophthalmology department for specialized care. On indirect ophthalmoscopy, look for fluffy yellow-white retinal lesions with or without intraretinal hemorrhage. So, coming to the diagnosis, CME retinitis is a clinching diagnosis. It's usually diagnosed based on recognition and characteristic of retinal changes observed through a dilated pupil during the ophthalmic examination. Diagnosis in that setting as a 95 positive predictive value. Apart from this, blood tests to detect CMV by antigen detection, culture, or PCR are not recommended for diagnosis of CMV end organ disease because of their poor positive predictive value. CSF typically demonstrate lymphocytic pleocytosis, low to normal glucose levels, and normal to elevated protein levels. Management CMV general considerations. General considerations under that patients with suspected visual impairment may be referred to as specialized care in the ophthalmology department. Patient diagnosed and requiring treatment may be intimated to SAGs for further support or treatment of CMV. CME should be treated for at least 3 to 6 months and follow-up should be done to make sure that lesions are inactive with CD4 count more than 100 for a period of 3 to 6 months in response to AR. Therapy should be discontinued only after consultation with the ophthalmologist, considering magnitude and duration of CD4 count increase, anatomic location of the lesions, vision in the contralateral eye, and feasibility of the regular ophthalmologic monitoring. Routine ophthalmologic every 3 months is recommended. Now, progressive retinitis. Preferred therapy, as we mentioned, Val, Valgan cyclovir 900 mg orally every 12 hours for 14 to 21 days. Then 900 mg once daily. So initially start with BD for 14 to 21 days and then taper it down to once per week. As an alternative therapy, you have ganciclovir 5 mg per kg IV every day, twice a day for 14 to 21 days. Um, so apart from that, then you can also follow up with valganciclovir 900 mg orally daily with or without intravenous injections of ganciclovir or foscanet 2.4 mg per injection. Repeat weekly until lesion inactivity is achieved. This is to provide higher intraocular levels of drug and faster control of the infection until steady state intraocular ganciclovir concentrations are achieved. So, what should you be noting? IV ganciclovir can be switched to oral ganciclovir if the patient is clinically improving and there are no concerns of gastrointestinal absorption. Phosco- uh, Foscarnet 60 mg per kg IV every 8th hourly or 90 mg per kg IV every 12th hourly for 14 to 21 days. Then 90 to 120 mg per kg IV every 24th hourly. Chronic maintenance therapy. CME treatment for at least 3 to 6 months. Lesions should be inactive and CD4 count should be more than 100 for 3 to 6 months in response to ART. Routine, that is every 3 months. Follow up with the ophthalmology department, as I mentioned earlier. Uh, Reinstituting chronic maintenance for CMV retinitis. That is CD4 count less than 100. Administer one of the systemic antiviral therapies listed above for the first 3 to 6 months until ART induced immune recovery. Valganciclovir 900 mg per oral BD for 14 to 21 days, then 900 mg once daily for period of 3 to 6 months until ART induced immune recovery. Then immune recovery uveitis might develop in the setting of immune reconstitution. Now if you have iris, then immune recovery uveitis, there may be a possibility. Periocular corticosteroid or a short course of systemic steroid could be thought of. CME esophagitis or colitis. So duration is for 21 to 42 days. Or until signs and symptoms have resolved. Preferred therapy, ganciclovir 5 mg per kg IVBD may switch to ganciclovir 900 mg per oral BD once the patient can absorb and tolerate per oral therapy. Alternative therapy or forscarnet 60 mg per kg IV thrice a day or 90 mg per kg IV twice a day for patients with treatment limiting toxicities to ganciclovir or with ganciclovir resistance. Oral valganciclovir may be used if symptoms are not severe enough to interfere with oral absorption. Treatment for neurological disease and pneumonitis. Now, doses are same as for as of CME retinitis. Treatment should be initiated promptly. Combination of ganciclovir plus foscarnet to stabilize disease and maximize response. Optimal duration of therapy has not been established. The role of oral vanzaclovir has not yet been established. Optimize ERT to achieve viral suppression and immune reconstitution. So, what do you need to understand is three very important things. Doses are as same as CMV retinitis, should be initiated promptly. The role of valganciclovir is still not established. ART optimum dosage for to achieve viral suppression and not initiate iris should be established. Combination of ganciclovir plus foscarnet is the optimum treatment. So coming to CME pneumonitis, doses are same as of retinitis. Treatment experience for CME pneumonitis in HIV patients is limited. Use of IV ganciclovir or foscarnet is reasonable. The role of oral ganciclovir has not yet been established. The optimum duration of therapy has not yet been decided. Coming to meningitis, so we've spoken what are the causes for meningitis. Coming to aseptic meningitis, so HIV itself or by another opportunistic viral infection like JC virus, CMV virus, mycobacterial infection, non-infectious inflammatory process, that is immune reconstitution inflammatory syndrome, or CNS neoplasia. A biphasic course with initial non-specific constitutional symptoms, followed by the classic features usually associated with meningitis, namely headache, malaise, fever, neck stiffness, rigors, photophobia, nausea, and vomiting. Skin rash, like the eruptions of varicella zoster, may appear concurrently. The typical CSF profile in aseptic meningitis is that of lymphocytic pleocytosis, normal or mildly elevated protein, normal glucose concentration with negative bacterial antigen tests. Management is usually symptomatic and sometimes specific antiviral may be required for HSVs and Epstein-Barr virus. Bacterial meningitis causes organisms are Streptococcus pneumoniae, H. influenzae, and Neisseria meningitidis. Symptoms and signs: fever, headache, neck stiffness, photophobia, vomiting, malaise, irritability, drowsiness, and coma. Symptoms tend to present within 1 week of infection and may be preceded by a prodromal respiratory illness or sore throat. CSF shows increased pressure, a high cell count, increased protein, and decreased glucose. Gram stain smear of spun sediment of the CSF. CSF culture examination and antibiotic sensitivity to be established. A full blood count should also be done along with CT scan imaging studies like CT scan, MRI to evaluate for any focal neurological lesions. Coming to bacterial meningitis, third generation cephalosporins like ceftriaxone, 2 grams IV BD is the preferred treatment. Vancomycin 15 to 20 mg per kg IV every 8 to 12th hourly may also be added if indicated as an adjuvant. Alternatively, penicillin 24 million units daily divided doses every 2 to 3 hours, or ampicillin 12 grams daily in divided dose of 2 to 3 hours. or chloramphenicol 4 to 6 grams IV per day can be given. Treatment should be continued for duration of 10 to 14 days. So coming to tuberculous meningitis. So varying presentation, TB of the CNS may present as meningitis, tuberculosis granulomas, or tuberculous brain abscess. So either it presents with meningitis or tuberculomas or as abscess. So symptoms and signs, the non-specific symptoms of TBM include fatigue, headache, malaise, anorexia, and vomiting. Fever, headache, vomiting, and weight loss are the most common symptoms. Cranial nerve palsies may also be seen on presentation, most commonly involving the sixth cranial nerve. Seizures, hemiparesis with pyramidal or cerebellar signs can be noticed. The CSF pressure is high, proteins are increased, and the sugar is low. There is pleocytosis with the predominance of lymphocytes. ATT with a standard drug should be given as per recommendations of the TB program. Additionally, steroids in the initial phase are helpful in reducing complications like obstructive hydrocephalus and vasculitis or any inflammatory reactions. Measures to reduce intracranial pressure should be instituted when you suspect. So, CSF findings in different neurological infections. So, in Cryptococcus, it is lymphocytic, it may be normal, protein elevated with low sugars. India Inc. is positive. Craig also positive. Organism isolated by subarachnoid dextrose agar culture. In MTB, predominantly lymphocytic, a few hundred WBCs may per ml, that is 60 to 70% of monocytes can be seen. Again, protein is elevated with low to normal sugar. Isolation of MTB in CSF by CBNAT and culture, uh, which are positive. Now, pneumococcus predominantly neutrophilic, greater than 1000 WBCs per ml, protein very high, very low sugar, gram stain again, and routine culture may reveal the organism. Syphilis, lymphocytic, mildly elevated, protein slightly high, and sugar is near normal. So, venereal disease research laboratory should suggest uh, PDRL should be positive. So, note lumbar puncture is always done when the intracranial pressure is normal, or there is papilledema suggests no papilledema. Coming to progressive multifocal leukoencephalopathy, it's a viral infection of the CNS caused by neurotrophic human polyomavirus or JC virus, that is John Cunningham virus. So, immunosuppression, classically occurring in the setting of HIV infection, reactivates the virus, resulting in brain invasion, destruction of oligodendrocytes, and their debilitating, demyelinating illness. PML has an incidence rate of 3 to 5% in HIV patients with AIDS. PML can sometimes occur in patients treated effectively with ART. Um, so PML manifests as low focal neurological deficits, usually with insidious onset and steady progression. The demyelinating lesions can involve different brain regions. Spinal cord involvement is rare and the optic nerves are not involved. Initial symptoms and signs usually begin as partial deficits that person may worsen over time. The time course of this evolving demyelination with clinical progression over several weeks often provides a clue to diagnosis. PML is sometimes mistaken for an evolving stroke, which, like PML, is bright on diffusion weighted MRIs. Headache and fever are not characteristic of the disease, and when present, may indicate presence of another opportunistic infections. Steady progression of focal neurological deficits show typical imaging findings of single or multiple hypodense non-enhancing cerebral white matter lesions. Lesions are hyperintense on T2 weighted and fluid attenuated inversion recovery sequences and hypointense on T1 weighted sequences. No mass effect or displacement of normal structures is usually evident. To confirm the diagnosis, PCR of CSF sample for the presence of JC virus DNA can be done. These are images suggesting progressive multiple leukoencephalopathy. Management and prevention, there is no effective antiviral therapy for preventing or treating JC virus infections or PM. The main approach to treatment is to preserve immune function and reverse HIV associated immunosuppression with effective ART. ART should be started in patients not on HIV treatment as soon as PML is recognized. HIV associated PML is often complicated by clinically significant iris that may require administration of corticosteroid therapy. Worse prognosis is also associated with high plasma HIV RNA levels at the time of presentation, poor virologic response to ART, and the presence of lesions in the brainstem. So the CT scan findings in HIV-related neuropathy. In HIV encephalopathy, you have cortical atrophy with bilateral basal ganglia calcification, with or without bilateral basal ganglia calcification. Toxoplasmosis, single or multiple ring enhancing lesions with mass effect, leukoencephalopathy. Tuberculoma, single ring enhancing lesions with or without hydrocephalus and basal meningitis. Progressive multifocal leukoencephalopathy, single or multiple hypotense lesions in the cortical white matter without contrast enhancement or mass effect, that is hyperintense lesions on the T2 weighted MRI. And what is and HIV associated neurocognitive disorders. Asymptomatic neurocognitive impairment is subclinical decline in cognition. Minor neurocognitive disorder is mild decline in cognition in addition to mild everyday functioning impairment that affects the more difficult activities of daily life. HIV associated dementia, significant decline in cognition along with significant degree of functional impairment that affects routine activities. The diagnosis is made in PLHIV with cognitive impairment after ruling out confounding conditions. So coming to HIV associated dementia, is more likely with CD4 counts less than 200, as we mentioned earlier. Acquired and slowly progressive cognitive decline, motor and behavioral changes, and non-focal or diffuse CNS signs. HIV associated dementia is a diagnosis by exclusion. ART is the most effective treatment, and ARV regimens should include agents that penetrate the CNS. HIV associated vacuolar myelopathy, the most common spinal cord disease in HIV. Vacuolization of myelin sheath, accumulation of foamy macrophages, and microglia with relative sparing of axons are the pathological manifestations. Clinically, this presents with slowly progressive leg weakness, which may be asymptomatic at first, with spasticity. That is dorsal column is that's posterior column for vibration. Position sense is lost. Sensory loss is there with ataxic gait, and urinary frequency and urgency is shown. Erectile dysfunction is an early sign in men. The diagnosis includes CSF analysis to rule out other infectious causes and thoracic spinal imaging, MRI, showing eye signal hyperintense areas or T2 weighted image, primarily in the thoracic region and affecting the posterior columns, which do not enhance with contrast. As such, there is no specific treatment. So, primary CNS lymphoma, about 2% of people are affected, people of HIV are affected, and it's the second most common mass lesions in AIDS. Primary CNS lymphoma is almost always associated with EBV and ubiquitous herpes virus. Um, it usually occurs when the CD4 count is less than 100. The presenting symptoms of primary CNS lymphoma include lethargy, confusion, impaired memory, headache, seizures, or focal weakness. Many patients develop cranial neuropathies or ocular involvement. CT imaging study shows periventricular irregular lesions that appear solid or enhanced in one or more sides. There is prominent edema. Lymphoma is suspected with the toxoplasma IgG when the toxoplasma IgG is negative or there is failure to respond to empirical treatment for toxoplasmosis. There is no cytotoxic chemotherapy for this disease. So coming to HIV associated neuropathies, distal symmetric polyneuropathy, mononeuropathy, multiplex, chronic inflammatory demyelinating polyneuropathy, progressive lumbosacral polyradiculopathy. These are common neuropathies seen in HIV. So coming to distal symmetrical polyneuropathy is the most common. The risk factors are older age, history of alcohol abuse, advanced HIV disease, prior use of neurotoxic ARV drugs. The most common symptom is paresthesia, usually beginning in the feet. The symptoms ascend over time as far as the thighs and will also involve hands in a glove like fashion. On examination, there are decreased or absent ankle jerks, diminished vibration sense in the legs, and increased threshold to temperature and pinprick. There is no specific treatment available. Coming to neurosyphilis, neurological involvement of syphilis usually presents in three forms. Is asymptomatic, acute syphilitic meningitis usually occurs within the first 2 years of infection, and some cases are diagnosed at the time of secondary rash. Patient with present can present with headache, meningeal irritation, and cranial nerve palsies. Abnormalities typically involving cranial nerves at the base of the brain. Cranial nerves like 2, 6, 7, and 8. Meningovascular neurosyphilis occurs a few months to 10 years. Average is 7 years. Prodromal symptoms include unilateral numbness, paresthesia, extremity weakness, headache, vertigo, insomnia, and psychiatric abnormalities such as personality changes. The focal deficits initially are intermittent or progress slowly over a period of few days. What are the signs? As I said earlier, personality change, ataxia, stroke-like symptoms, stroke itself, ophthalmic symptoms, bladder incontinence, dizziness, hearing loss, seizures. Signs of neurosyphilis include hyperreflexia, sensory impairment, pupillary changes, and optic atrophy. Diagnosis is by VDRL, presence of CSF pleocytosis in CSF. Pleocytosis usually 10 to 400 cells per millimeter cube and mildly elevated protein. Treatment: benzathine penicillin, 4 million units IV 6th hourly for a period of 10 to 14 days. Follow up the patients treated for neurosyphilis depends on the initial CSF findings. If pleocytosis was present, the CSF should be re-examined every 6 months until white blood cell count is normal. Retreatment should be considered if the CSF white blood cell does not decline after 6 months and does not normalize after 2 years. So with this, we've finished neurological infestations in people living with HIV. And Shweta, will you take over from now? Close.
Thank you so much, sir. Any
Yeah.
questions from the participants? Please feel free to unmute or you can put your questions in the chat box. Kiran sir, can you please confirm if mic access has been given?
Yes, yes.
Sorry, you are addressing me?
No, sir. No, sir. My colleague. Kiran sir, please confirm if mic access has been given. Yeah, participants can now unmute and ask questions. Piyusha ma'am.
Hello,
Piyusha
madam.
ma'am.
Hello, madam.
Yes, ma'am. Please go ahead.
Madam, in suspected CMV retinitis, the retinoscopy is compulsory, no, madam?
Ophthalmoscopy is a must. You should look for visual acuity, any blurring of vision, any gastrointestinal symptoms. You should look for even peripheral neuropathy and refer the patients suitably. Since cytomegalovirus is most common, retinitis should also be suspected. Also, patient with advanced HIV, you should also rule out other infestations like cryptococcal meningitis. Whether they are asymptomatic or no, you should look for serum create. Advanced.
Piyusha ma'am. Any more questions? So I don't think there are any more questions. Thank you so much for giving us time and facilitating these sessions.
Thank you, Shweta.
Thank you, sir. Kiran sir, can we quickly run the feedback form? Yes, thank you. The feedback form is now visible on your screen. All the participants are requested to please scroll through all the 5 questions and answer them. You can just click on the answer of your choice. Requesting all the participants to please fill in the feedback poll. In case there are any questions, participants can unmute and ask questions. Requesting everyone to please fill the feedback poll. Kiran sir, we can end the feedback poll now. Thank you. Thank you to all the participants for patient listening. Sir, can we conclude the session now? Thank you, sir, and thank you to all the participants for patient listening. We'll conclude the session now. Thank you, sir. Thank you, ma'am.